afternoon, everyone, and welcome to today's edition of Black Health Trust. We're so happy that you chose to be with us, and we think that you're going to enjoy the topic that is going to be discussed today. It is a previously shown show, but we received a lot of very positive comments, and it's very apropos for today since it's preventive health for women, and this is Mother's Day. So without further ado, I'll turn it over to our founder or to Dr. Walks. I don't know. Our founder disappeared. Dr. Maxie, are
There he
you
is.
on? Oh, there you are. I'll turn it over to our founder, Dr. Randall Maxey.
Hello, everybody. Thanks for joining us on this Mother's Day Sunday. I'm sure people are having dinner with their wives and mothers and aunts and other people, grandparents who deserve honors of today. We do have a timely topic. We're going to present the president of the National Medical Association, Dr. Yolanda Lawson. Let's start it, Simon.
Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend some time with us, and we are very excited to have you be enlightened by our speaker and enjoy what I think to be a very, very informative discussion. So without further ado, let me turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone. I hope everyone is having a great day. And I'm presuming everybody on the call woke up this morning, so we're blessed already. Yeah. I want to thank my co-moderators, Dr. Barbara Neighbor Stevens, Dr. Ivan Walks, and Dr. Jocelyn Hines. Thank them for all the time that we put in. We put in about 4 years, Barbara, I think. So good. And we've had a number of great speakers. So this is a special broadcast today because we are fortunate to have the current president of the National Medical Association to join us as our keynote speaker, Dr. Yolanda Lawson. And at her luncheon at the NMA, I must have eaten more gumbo. Years, Barbara, I think. So good. And we've had a number of great speakers. So this is a special broadcast today because we are fortunate to have the current president of the National Medical Association to join us as our keynote speaker, Dr. Yolanda Lawson. And at her luncheon at the NMA, I must have eaten more gumbo and watched people come in with parasols and dancing. It was really an affair to be remembered. And we love you, Dr. Lawson. We appreciate you taking the time out of your busy schedule to come and inform our audience about issues of maternal morbidity and mortality. So, as an introduction, I want to say that she is a fellow of the American College of Obstetrics and Gynecology. I mentioned she's president of the National Medical Association. She's board certified in OBGYN. Uh, she is in Dallas, Texas, and she is also an associate attending at Baylor University Medical Center. She's the medical director of Abounding Prosperity, a community-based organization that addresses HIV disparities in Target. I could read for the next 10 minutes and I wouldn't cover all of her accolades, but suffice it to say, we're very proud of you and very happy to be here. We also have at her invitation Dr. Haywood Brown. And Dr. Neighbor Stevens, could you briefly read his a brief part of his bio?
Well, Dr. Haywood Brown is not a stranger. He gave an outstanding presentation maybe almost 2 years ago, and I would encourage our audience, if you didn't hear that, look in the archives, and those of you who are new, maybe don't know that all of our programs since our inception can be found on our YouTube channel and Facebook. Um, Dr. Brown is someone who loves his work and has spent his career trying to improve the life and well-being of Black mamas. And I don't think he would mind me putting it that way. He is a um, former president of the American College of OBGYN, and is the prime mover behind the position that that organization took, uh, highlighting the problems going on with maternal morbidity and mortality and calling for changes in the way uh, medicine is practiced to try to improve uh, outcomes. Most notably, in my opinion, the things that were put in place to ensure that at least what needs to be done in the hospital gets done. And certainly, Dr. Lawson, if you disagree with or I'm incorrect, or as Rachel Maddow would say, am I stating this correctly? Um, that's not the whole story. Problems for maternal morbidity and mortality begin in the prenatal period, actually in the preconceptual period, and can
And
continue all the way through.
and let,
But
let
at
me
least some things that were put in place to help the hospital. Uh,
and let me add this to what you're saying. That there's recent information that shows that 82% of these deaths that you're speaking about occur in urban areas. And guess who lives mostly in urban areas? So this talk is very relevant to us, and we hope that our speakers will enlighten us on all the things that make our women at risk. Dr. Lawson, floor is yours.
Absolutely. Thank you, Dr. Maxey. Thank you, Dr. Neighbor Stevens. And thank you for the Black Health Trust for having me today. So, one of the things we hope to accomplish today, which is why I invited Dr. Haywood Brown, was we were going to talk about just really prevention in Black women's health. And we can discuss and talk about maternal mortality and morbidity. Morbidity is a discussion that we're having more and more about. And so, while we know that these rates of maternal mortality, and there's a disparity between Black women and white women in this country. One of the concerns that we're really emphasizing now is the morbidity. These women leaving hospitals intact and with the health they came with. And so it's an elevated discussion, but I think it's a discussion we should be having. In talking about preventive health care as a whole and as it relates to Black women, the first thing I hope that we emphasize today is the importance of treating disease earlier, no matter what it is, whether it's diabetes, whether it's heart disease, whether it's cancer. It is important that we are pursuing preventive healthcare measures so that we can capture disease early and treat and manage earlier. Because we all heard, I don't know, maybe I was in junior high or high school, early detection matters. So we hear these messages, but we have to really bring that home. And then when it comes to women's health care, I tell people my youngest patient is age 3, my oldest patient just turned 100. And so the spectrum around women's health care and what a woman needs during those times, right? Whether it's adolescence, whether it's early adulthood, and then that menopausal and geriatric woman. So there's an evolution of that. I hope today we can get into some of around that recommended screening that's recommended for these women, whether that's around cardiovascular disease, which is something I'm passionate about. So I have 3 pillars for this presidential year, and one is the Black Women's Health Agenda. And one of my emphasis points around that is in cardiovascular disease and Black women. And secondly, let's talk about today. I hope it'll we can really discuss around some of the recommended screenings, what people should be getting when, because sometimes our patients in the community hear sound bites. And so I have 25-year-olds coming in for a mammogram. right? But not necessarily, that's not necessarily a recommended screening regimen for that age group, but depending on risk. And so that's why it's so important to have a doctor you trust who can really guide you through life and what you need and when you need it. And so I'm going to start out, Dr. Maxey, if you don't mind, and let's talk a little bit about some of these recommended screenings. And then we can talk about even screening in the perinatal period, because that's another important thing. So, as we push collectively to improve the health of Black women, to improve the health of Black women in pregnancy, we have to just think about what their baseline status is and what they should be getting and when. And so when you talk about maternal mortality and morbidity, we know that there are three drivers of that. And that number one driver is cardiovascular disease, preeclampsia, chronic hypertension for these women. And the second that we look at is their risk of hemorrhage. And then thirdly would be sepsis. But one of the things I often talk about is that about 52% of the deaths that occur in these moms occurs the day after she gives birth. And so many times people tend to think of, oh, it's something that's happening in the midst of her labor, right? Not necessarily true. And then you think about throughout the trimesters, there are risks, right? It could be ectopic pregnancies, all of these things that can happen. But when we think about and drill that down to 52% of these women are dying the day after they get birth, that's significant. And so we need to be thinking about what are those drivers. And one of those significant drivers is around mental health. And so most of that comes from suicide and for substance use and abuse. And so those are things that we collectively, and so I think about this burden not only from the perspective of me as an OBGYN and my OBGYN colleagues and workforce, but what can others, emergency room doctors, our primary care doctors, our anesthesiologists, our behavioral health providers, I look at this as a multifaceted, multidisciplinary approach when we think about how do we save lives, how do we improve the health of Black women as a whole.
So, Dr. Lawson, I'm sorry, Dr. Maxey, I didn't wait for you, but Dr. Lawson, one of the things that I think we here at Black Health Trust really attempt to do is to give vetted information. What can we do and what do our audience need to do regarding understanding and hearing the right information? You kind of alluded to it with the sound bites. Could you, for example, tell us 5 things women need to do? I mean, certainly don't be limited to that, but at least 5 things that Black women need to do to take care of themselves.
Thank you, Dr. Neighbor Stevens. Thank you for that question. And yeah, I alluded to it. I didn't want to go into that's a whole section on misinformation and disinformation. I'm sure any of my colleagues in medicine would agree with me. But I am a proponent on improvement in health literacy for our communities, number one, right? And so I believe that health literacy, and I live in the state of Texas, and so there are things here, I think sexual and reproductive health should be taught in schools. And so those limitations, I think, have implications, whether that's on STIs, adolescent pregnancy. I even think there's a role when you talk about the maternal mortality piece, that education piece is needed. But 5 things we could do to improve the health of Black women. So, regular blood pressure screenings is number one. And so there is a campaign that's a coalition of multiple healthcare entities, and it's called Release the Pressure. And so the NMA is a partner with the American Medical Association, the Minority Health Institute, the Association of Black Cardiologists, and the American Heart Association. And what this campaign really did was looking at cardiovascular and especially hypertension in Black women. And so we have videos or we record how you properly take your blood pressure, how women can access blood pressure cuffs, what is the correct numbers. Much of our community may not understand. Their blood pressure, their ceiling for the top number should be 130 or less, and the ceiling for the bottom number should be 80 or less, right? So 130 over 80 or less. Of course, that's not optimal, but when we talk about a diagnosis of hypertension or mild hypertension, and so we have to be cognizant and make sure our patients and our communities understand what is a normal blood pressure. I'm asked that often. Secondly, we must work on obesity and physical activity in our communities. And so that is something that, especially when you look at Black women in this country, Black women are some of them have the highest obesity rates. And so that's a very important factor because it has downstream effects. Whether we talk about cardiovascular disease, the risk for diabetes, there are some cancers, right, that are related to obesity. Next, I would say our mental health. we continue we continue to deal with stigma around mental health. When you look at, you heard me mention around the maternal mortality piece and the importance of suicide and substance abuse in triggering those high rates. But when you look at 1 in 7 women will have perinatal depression, that's significant numbers. And so we not only deal with the stigma in our communities, we deal with access, right? What does access look like for us? And lastly, our willingness to get help or to speak up and to share. I just left Atlanta yesterday speaking around maternal and infant health at the 100 Black Men's Leadership Summit. And that's one things that we talked about. And we actually created a fact sheet for them of how they can help advocate for women and what should they be doing themselves, even though you may not centrally be the patient, of course. But how can you help these mothers and your sisters and your daughters advance the conversation? And then lastly, I'd be remiss if I didn't mention tobacco. For those people who smoke, we know that tobacco use is a leading cause of not only disease, death, and disability in this country. And so those are my five: tobacco, physical activity and limiting obesity, knowing your numbers around blood pressure and others, in controlling weight, as I stated, and then the mental health piece.
Well, thank you so much. Appreciate that. Our other co-hosts are on, Dr. Hines and Dr. Walks, and I'd like them to join in our discussion if they would.
So, Dr. Lawson, you mentioned perinatal depression, and um, if you could just talk for a little bit about what that looks like, because a lot of the things and feelings that you have when you're pregnant, especially towards the end, so I don't want to go out. Of course, I'm tired, right? Of course, I'm irritable. I'm sleepy, right? I haven't got good sleep. Some of the we know what the extremes kind of look like, but there's a lot of people in the middle who don't necessarily, or for those who are supporting somebody in that space, what are you really looking for? Because I think outside of those, TV worthy cases, we're not exactly sure what's normal under the circumstances.
Absolutely. And I thank you. And I really appreciate you asking that question because, one of the things I talked about this weekend was around many times women don't want to share with their OB, right? I'm a Black woman. I'm typically very empathetic and open with my patients, but they won't even want to tell me. Many times I do have the partner or the husband calling me. I had one gentleman outside in his car because he's like, Dr. Lawson, she'll get upset if she knows I'm telling you, but she's crying so much. And so sometimes, it's always been framed around the baby blues, right? And I can even speak to this outside of pregnancy. It's concerning that so many times women chop it up to it's my hormones. And so we have to be very careful with that messaging because that's pretty widespread now. I even have the men saying it. It's her hormones. Well, when we're talking about mental health, many times, and this is coming from an OBGYN, it's more than just your hormones. And so some of that excessive crying, lethargy, energy, apathy, losing appetite, overeating, sleep deprivation, we know that anxiety can be a very significant problem. So sometimes I have new moms, they don't sleep already because a baby needs to eat every 2 to 3 hours. And then they're up at the crib, they're checking every 30 minutes, afraid something's going to happen. That's anxiety and that's not normal. And so while she may not speak up for herself or recognize these things, those family members, those spouses, those boyfriends, those partners, they should be speaking up. And I'm pretty open with folks that it's okay to call me. But I've literally had that. I've had folks, I had one woman, she did call me. She's locked in her bedroom. Her and I'm like, "Well, where's your husband?" Because she was thinking about taking her life. He was watching the football game. She didn't want to let him know what was happening, right? But I was able to activate, get help out to the house, and get some interventions done. But that observation piece is so very important. But thank you for that question because I think it's important that we all think about how we can help and we all need to look out for the signs.
So, Dr. Lawson, I want to go back to something you said a few minutes ago before we lose that, get too far from that train of thought. You cited the fact that 52% of the mortality occurred within 2 days of delivery. But what about the, let me do the math, the other 48% that fall outside of that window all the way to the end of the 12 months out? Could you speak to that for just a moment?
So let's make sure I'm clear. 52% of maternal deaths occur the day after a woman gives birth. So that's right after she gives birth through that entire postpartum period. So that's why this discussion about extending postpartum Medicaid is so important. From the World Health Organization's definition of a maternal death, it's any woman who dies at any point during her pregnancy up to 42 days post birth. And so many of you may remember, I remember when I was a resident physician, many times women's Medicaid may last them 4 to 6 weeks. We were trying to squeeze as much health care into that month after birth, get them on birth control. If they were a gestational diabetic, get repeats. We were trying to do everything we could within a 4 to 6 week period, right? And so that's why this policy decision on expanding that coverage to that year after birth, because again, that is significant. So when you talk about what's happening in the midst of the pregnancy, right? You know, I talked about cardiovascular disease, hemorrhage, and sepsis, right? Those would be things that may happen within the pregnancy. And of course, a leading indicator would be ectopic pregnancies, especially ruptured. And then in the postpartum period, we still have this cardiovascular disease. A lot of times people think that just because they made it through pregnancy and delivery, they don't realize you can still acquire preeclampsia postpartum.
Yeah.
Right. Many people don't understand that. So, when a woman's having visual changes, extreme swelling, there will be some swelling. I explain to patients normally that first week after birth. That's going to happen. You've typically had a lot of fluids and there's a lot of shifts. But when there's headaches, visual changes, I encourage all women to buy a blood pressure cuff, right? When they're pregnant, they need to continue checking even in the postpartum period.
So,
But swelling in the hands and the feet, swelling that doesn't improve,
so Dr.
right?
Lawson,
Upper quadrant abdominal pain. So all of these can be factors and symptoms women can experience even in the postpartum phase.
can you, for the sake of our audience, before Dr. Walsh comes in, speak about what is preeclampsia and eclampsia? Just what is it?
Yes, so preeclampsia is a condition that pregnant women can acquire, and typically your blood pressure is elevated. Typically they have swelling, and typically we want to check their urine because they begin to spill protein in their urine. So this is a spectrum disorder. You just heard Dr. Maxey mention eclampsia, but even before you get to preeclampsia, there's another disorder which is just called gestational hypertension. They may not be preeclamptic, they may only have high blood pressure, but not some of the other clinical parameters, whether that be abnormal lab results and other physical manifestations of preeclampsia. So there's gestational hypertension, then you can get preeclampsia, and you can get preeclampsia with severe features. And preeclampsia is dangerous because it not only can affect the mother, but it also can affect that unborn child, right? And so by causing abnormalities with the placenta and other issues for the baby. So sometimes delivery is indicated not only for maternal reasons, but also for fetal reasons. And then the spectrum gets more severe when you go into eclampsia, and that's when the blood pressure is very elevated, but at that point, the woman conceives, right? And at that point, we're worried about oxygenation to the baby, and brain injury to moms. Sometimes women can even stroke. And so eclampsia is the most severe form of that, if that helps, Dr. Maxey.
Thanks very much. It does. Dr. Ivan Walks.
Uh, Dr. Lawson, I want to thank you for two things, and then I want to ask you a question. The first one is thank you for being with us. It's such an honor to have you on the Black Health Trust. And the second thing I want to do is thank you for being one of those very smart doctors that knows how to talk to people in plain English. For
Thank
those
you.
of us that went to public school, it's really nice when we have people that are very accomplished who are able to, as we used to say, break it down so that folks can understand and take away things that are useful for them. You mentioned, I was very excited to hear you mention talking at the 100 Black Men event and hearing you talk about some of the partnerships, because so often in healthcare we focus on the health issues and the health concerns. And I wanted you to talk a little bit about some of the other aspects of that. What's it like to be challenged with I don't have enough food for my family. I don't have the resources I need. I'm too far away for follow up when I go home from the hospital. There are other things other than just the important checking the blood pressure, making sure that the screenings are done that impact people in really profound ways when they're trying to do something as as wonderful as bringing another life into the world. But what am I bringing them into? What home am I taking them to?
Thank you so much. And I just want to share with you, breaking it down is my superpower. That's I'll break it down to the people. I'm real good at that. And so I love that you asked the question because I think what you're asking is around the social determinants of health and what are some of these social factors that contribute to those that may have other medical disorders and conditions. And so Friday, yes, I was in Atlanta for the 100 Black Men's Leadership Summit. Thursday, I was at the Clinton Presidential Library. And actually, this was an interesting, I spoke there on specifically maternal health, and it was hosted by philanthropy. So Winthrop Rockefeller, the Clinton folks were there, Walton Foundation, and the Surgeon General of the state actually came, who informed me publicly, and she informed the people publicly, she really didn't understand that this spoke to me then, right? It spoke to me then that there is still a place to educate. And I actually did that. I made sure that I educated, but it was an interesting setting. So not only clinical folks, policy people, and philanthropy, and thinking about philanthropy's role, we should do that. And to speaking to this, that morning I actually testified before the Arkansas Congressional Black Caucus. And some of this was around disparities, including maternal health, but also thinking about some of the social factors. And so after my presentation, they probably held me in that room at least 90 minutes to almost 2 hours asking questions. And one of the things they brought to the table are, how do they connect with clinicians because they need the expertise, and specifically the expertise of Black clinicians, because many times our perspective is a bit different, because we tend to be closer to our communities and have perhaps lived in these communities. I know I can speak to that self. And so it's interesting as we think about policies moving forward. And I have a huge interest in that piece, but protective policies. A few years ago, I did a presentation to legislators around how using Medicaid as a tool for health equity and to close the maternal mortality gap. We have to think in those frameworks. And I think that the contributions we add in these conversations is specific, just because, like I said, many times we're closer to these communities, and I'm told often they're hard to reach. They're hard to reach. But one of the things the legislators talked about, transportation. What's the role there? And so Dr. Maxey, in the introduction, he mentioned that I'm the medical director at Abounding Prosperity. It's a community-based organization. And there we deal primarily with HIV disparities. It sits in a medical desert, right? And so we're strongly encouraging medication compliance, right? If we want to end the HIV epidemic, people got to take their meds. One of the things that we've instituted and found very helpful is Uber Health. And so Uber Health has been a game changer for us to ensure. And so I'm the principal investigator on the study right now, and it's the injectable PrEP. But the problem is you got to come and get your shot.
Well,
So we instituted Uber Health to help eliminate that transportation barrier. And so we know that there is a need for economic empowerment in our communities. We know this. And so, but with where we are, we have to meet people where they are right now. Exactly right. And so we continue to, and so I'm hoping that we can continue to push forward from the policy side, that the National Medical Association, I'm planning some high level policy work coming up. I can announce, and I don't know if it's okay today, but I will share that if Dr. Max, if we have time at the end, that how we can work collectively to engage our policymakers on things that will improve the health of our communities specifically.
well, thank you. It's mind blowing that a person who's in charge of public health for a state had no idea this is the problem. That sounds very suspicious to me. And this has to be on purpose. Let's. I know we have some questions from our listening audience. Simon, by the way, is Dr. Brown on yet?
I don't see it yet.
Okay. Uh, Dr.
There is
Neighbors,
a question from the chat on YouTube. And the question is, can you speak to the accuracy of blood pressure cuffs sold in pharmacies? And are there units that are better than others? And not just units, but locations, right? Because they have everything from fingertips, wrists, arms, ankles. You can take your blood pressure all over the place. So
Absolutely. Thank you, Dr. Hines, for pulling that question out, because I do think it's important. And so one of the things that I do, and so with this Release the Pressure campaign, and I'm happy to send information to the Black Health Trust to disseminate it through your channels. We actually list the brands, right, that are usually found to be most accurate. The second thing that I do with my patients personally, I ask them to bring their cuff to my office, right, where I can make sure what I'm getting, right, from a manual pressure is and their machines are equilibrated and reading accurately. And the other thing that I do is many of the community pharmacies, Walmart's, Kroger's, grocery stores have blood pressure cuffs machines in their pharmacies. I tell people check it there too and make sure, right, that you are checking it even outside, even if they're not coming to me. Most pharmacies are equipped to check it there also. But there are resources around some of these machines and what's equilibrated. And I see Dr. Williams is on here. I don't know if he wants to comment on that at all.
Dr. Williams?
I think you're on mute, Dr. Williams. And then someone put in the chat cuff size. And so typically when for me, I actually a lot of times order the machine for my patients, and I make sure that I put on there what cuff size they should use. But then also, I encourage them, if they're unsure when they go to the pharmacy to buy it, to also check with their pharmacy and make sure it's appropriately sized. Because if you buy a cuff and it's too small, right, you could get an elevated reading erroneously.
And that's an extremely important point, Dr. Lawson. 2 weeks ago, there was an article in JAMA which emphasized that point, that many of the blood pressure cuffs that are used, for instance, in pharmacies are the wrong size, or the blood pressure cuff that an individual purchases may be too small. Many of our ladies have somewhat copious arms, and the cuff may be too small to accurately measure the blood pressure in them, and so there may be an underestimation of the blood pressure, and as a result, the person may not know that they really have hypertension. I wonder if I could ask a question of Dr. Lawson at this point in
Sure.
regards to the issues of preeclampsia and eclampsia. Um, there was also an article that was published showing that the use of prenatal aspirin in especially in Black women may perhaps avert the problem of eclampsia if used before the 20th week. Do you have any comments about that? And if so, if you think that this is a good idea, should that be extended to all Black women who are pregnant?
Absolutely. Thank you, Dr. Williams, for that question. And so it's been depending on your generation of practicing OBGYN, it is not unusual for us to use aspirin, especially for women who come into pregnancy already with essential hypertension or chronic hypertension. So for those women, pretty much across the board, we are going to encourage aspirin therapy for that particular age group women. The other women we may encourage it for are women who have strong family histories of hypertension, right? And so, by nature, physically and physiologically, when you get pregnant, your blood pressure is lower. So, in the first trimester of pregnancy, women typically demonstrate a lower blood pressure. It will become towards baseline in the second trimester. And then you're right, we can begin to see, because we know that pregnancy can aggravate blood pressure. That's just what it is. And so that's why we are so aggressive many times around managing and controlling the blood pressure. But
And
yes,
what specifically
we
that
do.
aspirin going to do?
We,
I thank Dr. Lawson for her wonderful discourse to us on this Mother's Day, talking about maternal and fetal mortality. And in lieu of this special Mother's Day, I know a lot of us want to get back to our dinners and celebrations of our loved ones. I'd like to ask Dr. Walks and Dr. Neighbor Stevens to have, and Dr. Hines to have final words. And we certainly appreciate Dr. Lawson for allowing her to have us again. And we'll have her again as soon as possible. Dr. Walks?
Thank you, Dr. Maxey. My final comments for the day are just to just reemphasize how important it is, as Dr. Lawson began with talking about prevention and maintenance of good health. Most of us come into the world with good health, and it's up to us to preserve it and protect it. And just the importance of recognizing that, as Pastor said in church today, that um, mothers are imperfect and perfect at the same time. And we should just continue to honor and appreciate our moms on Mother's Day.
Thank you, Dr. Walks. Dr. Stevens?
Thank you, Dr. Maxey. Thank you, Dr. Walks. And thank you, audience, for supporting us through all of this. As you know, Dr. Maxey doesn't think we should take the time off, and I understand where he's coming from. And I think that if we want to continue to make, I hope, an impact on the overall health of our community, we have to continue these kinds of talks. These are the kinds of talks we just must have. And we will certainly try to continue to do that going forward.
Well, thank you so much. Again, thank you, Dr. Lawson. Thank you, Simon. And everybody have a happy Mother's Day, Grandmother's Day, Auntie's Day. For all of those here, have a great Sunday.
Bye.
Good day, everyone.
Coming for barbecue, Dr. Walks.
Anytime.